Good afternoon. I do feel like I'm a bit of I'm a former healthcare CEO, and I have come to the light side from the dark side. So just want to talk a little bit about what's going across the marketplace. We know that healthcare continues to be a challenge. Regardless of all the things that are taking place in the market, the costs are going to continue to go up. And even though we've seen a delay or a slowing down in the costs, we see that there's a lot of things that have just been delayed or put off. We have the Affordable Care Act. We know that there's going to be more people covered. We know there's not enough primary care physicians. We know about the ACOs. And let me just say something about the ACOs. I think what people aren't recognizing, and you tie these two together, primary care and the ACOs, is that the ACOs are essentially saying to providers, we want you to be responsible for the care that you're giving and that you're delivering. But what that means is they're actually going to probably be about 30% less productive, so that's going to put another crunch on your primary care access. Cost shifting to patients, we've all seen that. I think we've done as much as we can do to share the costs, shift the costs, change the costs, design our benefit plans, and look at that. And thank you to Cypress for educating everybody, because there's really a lot of options out there, but the patients really now are recognizing that there's not a lot of places to go. So patients are delaying their care. And it's creating some serious problems for people. Employees are more mobile. What that means is that your retention rates start to be affected as well, right? People can get health care anywhere. It used to be that your salary and your benefit plan was something people took into consideration. Now it's something that they realize that they are entitled to, and they're moving around a lot more. Who is going to actually have the interest of your own on your behalf of your patients? Well, the providers, the way they currently are listed, they are not necessarily going to be concerned about your results. It's funny because I was on a panel at HIMSS conference. I don't know if any of you know what HIMSS is, but it's the National Technology Association. And I kept talking there on the panel, we should worry about what the employers, they're paying for everybody. But it was a healthcare system group of people, and they all kept looking at me like, well, we get our money from other people. And I was like, no, you get your money from the employers. You should worry about them. Insurance companies, they manage risk. We know that the retail people are in our market space, and everybody wants your healthcare dollar. If you're like me, you see an urgent care center in almost every corner. Wellness companies are still out there, and they're reinventing themselves, but it's a little bit hard to see the ROI on the wellness companies. So the bottom line is, it's your money, and you need to know what's going on with your money, and you need to be responsible for your money. I'm going to let David talk about healthcare more.
Well, good afternoon. I'm David Claud, and very much appreciate the opportunity to be here, and appreciate from Deb the opportunity to talk about healthcare. That's an invitation to a very broad topic, and I'm going to take advantage of it. That was a joke. I think apparently I see some Diet Coke. Just have some Diet Coke. Just get you going. Okay. So, anyways, this is a fish diagram where basically you attempt to identify what are some of the problems that have gotten us to where we're at, what are some of the root causes per se. What's gotten us to the point where healthcare costs are growing so much, and so I want to talk about this, what you'll see in these slides, just in the context of pre-diabetes, just so that, I mean, these reasons. I just want to highlight them and explain what they mean. So the first thing you see, patient behavior leads to chronic disease, which is 75% of cost. So let's just talk about kind of what does this mean in terms of prediabetes. I don't know if you're aware of prediabetes, but in a nutshell, prediabetes is a condition that can be diagnosed, and there is a predictable progression to diabetes. And according to the CDC, about 1/3 of adults in America have prediabetes. The percentage of those adults who are aware they have prediabetes is only 10%. So only 10% of these people who have a condition that could progress to diabetes know it. And that wouldn't be a problem if there was nothing that could be done. But it is a problem because there are things that can be done to reduce the progression from prediabetes to diabetes. And the things that you can do have to do with losing 5% of your body weight, and then also just moderate increase in activity, brisk walking, 150 minutes a week. So patient behavior leads to chronic disease, which is 75% of the cause. That's the first root cause. U.S. culture reinforces habits that are not healthy. Deb just said I should say, Viva Las Vegas. I think that explains it. I just wanted to give credit to where that was. You got the biggest laugh so far. Okay.
No.
So current health system not designed to prevent or manage chronic disease. I think prediabetes is an excellent example. We're not, in general, the system doesn't encourage physicians to identify patients with prediabetes, nor give them credit to reduce the progression from prediabetes to diabetes, number one. And then even if prediabetes is diagnosed, the system is not designed. It's much more going to be like, well, you have prediabetes, you need to exercise more, eat better, and and then we'll just see you when you come back again. Healthcare continuum is difficult to navigate and is paid for more illness. So with prediabetes, the way I would give you an example about this, prediabetes probably is diagnosed or could be diagnosed when a woman is pregnant. Anytime a woman is pregnant, there's testing for to see if the patient has gestational diabetes. If the patient has gestational diabetes, at that postpartum visit, it's recommended by ACOG that they test for underlying diabetes. That's a perfect time to identify somebody who has prediabetes. But even if that is done and that patient is diagnosed with prediabetes, the likelihood that there's a handoff between the OBGYN and the primary care physician is very low. And then healthcare information fragmented across users and not leveraged. Just with respect to prediabetes, again, who knows? There's not a lot of connection between all of the players. The entities that know a patient or a group of patients has prediabetes don't communicate that information to an entity that can do something about it. I'm going to turn it over to Deb before I get pushed out of here.
Let me just say what Activate Healthcare is about. We really bring primary care and we try to manage the total population. But as we all know, there is only one person in the exam room who can actually make an impact on the care, and that is the patient. You can provide as many services as you want, as many resources, but if the patient isn't compliant, they don't understand it, they don't appreciate it, you're not going to see a lot of changes. The current health system is not set up to prevent chronic disease. What they are set up is to take care of chronic disease. So they're going to give you quality care and they're going to measure quality care, but they're not going to prevent the care. And also, the people who have the biggest impact on anybody's health really is the employers along with the health system. So your culture, your impact, your influence, your guidance, your leadership will really help to create and set the pace. Managing the continuum. That's really about looking at the whole person and managing the total care. That's not just you have a cardiologist, you have an endocrinologist, you have a GI, you have pieces of that patient. You need really one person to manage that care. And leveraging the communities, that's really about, in America, there are 90% of the companies have 1,000 employees or less. But the people who have opportunities for clinics are employers who have more than 1,000 employers. And so we've created a model where we can bring all the employers together and create that access for people. And of course, you want to be able to manage the total information around that patient. Again, not just what's happening in the clinic, but what's happening on the outside, what's happening with the health system, what's happening with their other care. You want to be able to look at that completely. And everything coming together to give that information and manage that patient will actually give you the results. Anytime you want to say something, you can jump.
So,
it's breathing over my shoulder.
I don't think that's the case. So all of our, the highlight of the slide is all of our solutions are geared to be driven through the patient. And so that we're constantly focused on, well, so if you want to, alluding back to some of the presentations we've had before, we had an excellent presentation on chronic kidney disease. And so if we want to make sure that, if you want to make sure that your patients that are headed towards dialysis do that in a fashion that makes sense for everybody. We want to do this through activating the patient. So, go ahead.
So when we are looking with an organization or a group of organizations, what we try to do is we create a clinical team. And the clinical team consists of primary care physician. Why primary care physician? Because we want somebody who's going to manage that total person, all of their health issues, all of their care, that continuum. And they can do minor management. They can do cardiology, GI, the endocrine. They can manage that total person, looking at that patient as one. We want to do a nurse practitioner as health coach because, and there are a lot of people who do coaching, but we believe that a health coach, people believe in health, people want to know about their health, but if they actually get it from a person who's coaching them on their behavior, they can say to them, here's what you can do to avoid becoming pre-diabetic, and here's what it means if you do become diabetic. And then we have our phlebotomists and our assistants. Our team cares for 2,500 to 3,000. And let me give you an example of how that team looks. We just opened up in Ohio, and we opened up with an organization that had 1,600 members, 400 members, 200 members, and we are adding some people who have 25 to 50 members. They have access to this near-site clinical team 40 to 48 hours. Most people are seen 99.9% of the time the same day, and they're proactively managed by the health coach and the primary care. So here's what you can get out of that clinic. When we go in, we try to look and see, where is every one of your healthcare dollars spent? What's going on? Today, what happens with the patient is they may have a primary care physician, but you have to ask them when was the last time they saw the primary care physician. They may go to an urgent care center, so if they can't get into their primary care doctor, they'll go to your local urgent care center, your emergency care center, so you got somebody else now involved. You may have a health coach that's working with the carrier or working from some other place, and you have a different occupational health situation team carrier. So now this patient, this one person, has 4 different or 5 different things going on with them. Nobody's really pulling all that information together and available and accessing and caring for that total person. When you have an on-site clinic, you can get all of this care for your person, and you can understand it. It's a world of difference when you've got somebody who understands the total patient. We have our providers now are saying, geez, as a community person, had I known the work that these folks do, I'm not sure I would have returned them to work. Or I don't know if this was the right thing for them, or finding somebody who gets the symptoms treated all the time at an urgent care center, but then actually having somebody as a primary care doctor who can look at the patterns and avoid a disease or a concern, that is huge. You'll see a tremendous amount of benefit from that. Let me just say one more thing before David jumps in. We also believe that culture is very important. You saw that on our swirl. We do not staff these clinics. We actually collectively hire to your culture because it's extremely important for you to be able to recommend to your employees. I had a part in selecting and interviewing this provider team. And this team, we want the team, and I've hired thousands of providers, we want the provider to say, this is my population to help manage and make better. So it really becomes a great fit for everybody.
Okay, this slide describes one of the fundamental aspects of our model. So we work very hard to get employees to, I should say encourage employees to come into the clinic and have a visit with a physician and a health coach. And one of the reasons why, there's been a lot in the press that maybe you've read about questioning the value of an annual exam. This, I would just say, this is way beyond the typical 7-minute or 10-minute annual exam that happens. This annual exam, I just want to highlight on the slide, 30 minutes with the physician and 30 minutes with the coach. Without this time, if you have a very, very short visit, the stuff that we all in this room want to happen, it's not going to happen. So Deb and the other co-founder of the company are very committed to our providers having significant time with the patients. And so that's one. So what do you do during that time? Well, first of all, you identify if there's any risk factors and figure out what meaningful steps could be taken to mitigate the risk factors. But beyond that, though, there's a relationship built. I'll just give you a personal example here. Deb said humor was okay. So do you remember? Isn't there's some commercial about that hair transplant, and the guy says, I'm a customer myself. He owns the company. Well, anyways, with Activate, I'm a patient myself, and I was in Indianapolis and playing basketball, and the next morning, well, I had an injury, and the next morning I could not walk, and so bottom line is, when you're in a situation like that, unless you have a relationship, which I did as a patient with a provider, you're not going to go try something out new. Where I would have gone, I would have gone to a orthopedic urgent care that was part of a health system, and I would have incurred a significant amount of costs. Because I had the relationship, I got into the clinic, and then that physician evaluated me. Imaging was recommended. I went to get the imaging at a place that met the clinical needs, and also was where cost could be brought into the consideration as well. And so that's another reason why we work so hard to get patients engaged in the system and to get them involved with their health. The last thing I will say is, why do we do this? What's the whole point? Well, our company's name is Activate, or Activate Healthcare. We're looking to make sure that patients have the knowledge, skills, and confidence, not only to deal with their medical conditions, but also to deal effectively with the healthcare system. So that means when they go to see a specialist, we want to make sure that they're prepared to confidently ask questions with the specialist. Or if they are at home and they have some symptoms, we want to make sure that they're confident about, well, what's the appropriate level of care that is needed. Is this something that I need to call about? Is this something that I need to go someplace about? If I do need to go, who do I go? So that's also what happens during this process.
Can I just add something?
Yep.
One of the reasons that when we set up the company, that we wanted to be able to do this is, first of all, the best claim or the best care is never having to receive that care, right? So what we want to do is, when we go into your organization, we ask everybody to plan a comprehensive wellness physical, because it is amazing how many people are seen in the healthcare system that are seen over and over again for the same thing, but nobody ever stopped and said, what's the root cause, what's happening here, and how do we prevent that from happening? So we really try to work out a systematic plan to touch every eligible member, to have them have this comprehensive wellness and physical. And I like to look at it as, this is the first day to your step towards health, where there are no questions that shouldn't be asked. If you have any concern, any issue, you come for a physical. It's not like the regular physical where you say, by the way, I have this rash or this GI problem. They say, go out front and make another appointment. If you have that issue, it's taken care of in that comprehensive physical. Then you are introduced to your health coach, who's going to say, how do we make sure that we manage proactively your care? And then we follow them, and we have goals for them, and we stay in touch with them. And we have the same continuity of team that's treating you for the acute care, all those services that were before, but this team now is proactively managing your care, which is amazing. As David was saying earlier, people don't know they're diabetic, they don't know they're pre-diabetic, all the silent killers. We actually get that 50 to 70% of the population that's not in your current healthcare claims right now, and we're helping to manage that 20 to 30 that's driving your healthcare claims, because we touch everybody in this process. Once we know about everybody, we are able to use telemedicine. We have plumbers in Detroit, and we know that they travel. And one of the things that's really important is that they shouldn't have to always travel back to the clinic. If we know everything there is and you've gone through that comprehensive physical, we can now set up ways to communicate with you better. And that means what works in your schedule. By the way, our hours of our clinics are set up by our customers, so some of our clinics open at 5 a.m. in the morning and some go to 7. I will tell you that because there's so much access Monday through Friday, nobody wants to see the doctor on Friday afternoon and nobody wants to see him on Saturday morning. We do it now because if we can get in, we're lucky. But if you have your own clinic, you have the luxury of establishing those hours the way you want to do it. So we really trying to find better ways to communicate with your population.
Okay, so this slide has to do with medical referrals. Coming at it from a clinical standpoint, I think the first question is, is a referral needed to a specialist? So to answer that question, first of all, I would go back to the time. The physician needs the time to interact with that patient fully to better understand what is going on, so that they can practice at the top of their license, so to speak. So that the primary care physician, we don't want time or insufficient time with the patient to prevent the primary care physician from being able to take care of a clinical problem that they can take care of. Then, if it's beyond the capacity of a primary care physician to take, then the next question is well, who is the right specialist to go to, but also how can we best prepare this patient for success when they interact with the specialist? So what that means is, does the patient have, if the patient's going to see a specialist, does the patient know why they're going? Do they know what questions would be appropriate to ask so that the decision can be made kind of on the patient's on the patient's terms? Getting back to a comment that was made earlier today, somebody from I think it was DCC, I believe, but 90% of dialysis in this country is done in-center, in the DaVita, Fresenius, et cetera. That's like 3 days a week. And the comment was made that in other countries, it's most of it in third world countries, most of it's done at home. But in Europe, something like 50% is done in home. And so the point is, from a medical referral standpoint, you have to give the patient the confidence to interact with the specialist so that the decision about, for example, where dialysis is done is made on the patient's terms. And if you don't give that patient confidence, imagine yourself how often you've gone to see doctors and how quickly you've come to the realization, oh, well, these questions must not make sense or whatever. So that's another aspect of managing this whole process, is giving the patient the confidence and the tools to be prepared for success.
We also, your clinical team tends to know your benefit plan probably the best as anybody, because they will want to make sure you get the high quality, right cost copay. We know there are variations in the cost of any imaging. You can get an MRI for $600, you can get it for $3,000, you can get, we had a joint replacement the other day that was discounted for $200,000, but the same quote in another state was $65,000. So I mean, you've got these variations. So the first thing you have to look at is it appropriate? Will a person be compliant? What does their benefit plan call for? Who is high quality, cost effective?
Okay.
One of the things that we also do is we try to understand the culture of your organization. So we tend to look at what is a culture and how do we execute a culture of health with working collaboratively. Lots of times when we go to open up a clinic, we have a wellness council team, which will look at the culture and help establish the hours for the clinic and help with the communication plan and the process, and look at the benefit plans and how do we have a guidance for what's best usage of the clinic. One of the things that we know about employees is that they love to hear what upper management is doing and what they're up to, but they trust what their peers say. So we try to make sure that all of those pieces are tied out and they become a good communication plan. We have yet to open up a clinic where we haven't had huge demand waiting in line to be able to get in to see the clinic.
Yeah, I want to add something about this culture of health. Deb mentioned the presence of wellness cultures. Part of the reason for wellness cultures is to ideally make it easier for patients to do the right thing, so to speak. So just a personal story. I was at one of our clinics about a month ago, and I was in the restroom, and while I was in the restroom, there was a little flyer about how maybe actually you should think twice before you pick up that can of Diet Coke. And it was just reinforcement of a message that I had heard in the clinic. And so this whole wellness culture, it works to create this culture that makes it, that gets everybody rowing in the same direction.
You can all give up your Diet Cokes now. So no. The other thing is we really do try to make communities of health. I will use our Defiance Clinic again, that we brought the three organizations together. That has been a fascinating process because we now have a clinic. We have fabulous quality doctors. Everybody's able to see these providers. And I bet you I give a tour there every week. It's a town of 18,000. We're probably going to have 3 or 4 clinics in that community. Why? Because employees now see they can have a primary care managing their care. They have a health coach. They have their generic drugs that are on site prepackaged that they can get. The labs are free. And the quality of care is so much different because now somebody actually really is caring about them. So we hire our clinical team full-time, and we hire them full-time because we want to train them on who's the most important in the clinic, that is the patient, and that the person who should be doing all the talking is the patient, and that we should create a non-judgmental environment. That means listening to the patient and their values, not pushing our values on them. So once you have a clinic that's been experienced by the community, it tends to change the community. Information is key. We really work with brokers and TPAs because we want to make sure we're sharing all the information. As we know, patients don't always tell the full story or the whole story, and having all of that information available to your clinicians and your clinics and on-site providers allows you to be able to provide that total care to that person. So we look for real-time data, but we also on a monthly basis share the volumes that we're treating, the types of people we're treating, the things we're treating, the goals and objectives that we've established. So we really use the data to try to match up with what your experience has been, but what we're driving and the changes we're making. We always manage to an ROI, so we want to make sure that you're getting the value for what you get from your clinic. And again, because we know and our providers are hired specifically for your organization, we figure out the best way to communicate with your population. So that is mobile messaging, telemedicine, digital monitoring, patient portal. I was just meeting with people earlier where they really think the patient portal is great for their folks, but other people will think telemedicine is great. So we set it up in that capacity so we know how to best communicate with your population. So what's happened with our experience now that we've been at this for quite a few years? My 25 plus years have been added now to 6 on top of that, so I've been around for a while. We have higher member participation. And I can tell you as a healthcare CEO, it's kind of freeing to the employers that have this information now, because when they have 80 to 90% participation of their members, and we can sit down with them at the end of the year and say, here's your priorities for your population, they can now use their cost savings to help create programs that are really going to be geared exactly towards that population. So for instance, we know we have a trucking company. They have truck drivers. What's the problem with truck drivers? They never can find a place to eat that's nutritional. So now what the company does is when the truck drivers come in to get their sheet of where they deliver for the day, they reach in the refrigerator. They can get pre-cut and pre-packaged vegetables and fruits that they take with them. So we're just constantly working to change that culture because they now understand what's going on with their priorities and challenges are for their population. We have yet to open a clinic where we haven't been able to show cost savings in the first year. Did not anticipate that when we started it 6 years ago. We thought, gee, we're going to find a lot of people who may have needs that we don't know about. But I got to tell you, there's so much overuse in the current healthcare systems that managing that population proactively and effectively, there's a lot of reductions that can happen. Creating that access, having a non-judgmental visit really creates a lot of improvement in that care, in that dollar line. Do you want to say something?
Deb is my boss too, so this makes this a little bit challenging. And we had some Cliff Notes on our table, and then they disappeared over lunch. So that's
Somebody knows our presentation.
But anyways, I know that sounds like the dog ate my homework, but this is a little bit of a tough crowd too. But Deb mentioned the word overutilization, so I just that is a cue to an initiative called Choosing Wisely. Has anybody heard of Choosing Wisely? I'm just curious. Something I think this is one of the better things going on in medicine right now. So the American Board of Internal Medicine, about 10 years ago or so, came up with a new physician charter, and essentially the charter was, well, how can we be professional? How can we be responsible with our profession? One of the things that they said in their charter was that given the realities of limited resources, we have to incorporate cost into our decisions. Yesterday there was that talk about hepatitis C and the costs associated with the medications that can now essentially cure hepatitis C. Well, I mean, in light of the fact that you can only spend $1 once, how do we make sure that every dollar that's spent is needed so that the dollars are available for treatments such as that, the direct antiviral treatments for hepatitis C? Well, so that is what the Choosing Wisely campaign is all about. Choosing Wisely, the American Board of Internal Medicine went to the physician specialty societies, like, for example, American Academy of Family Practice, and they said, give us a list of 5 things that you think are being done too much that both physicians and providers should question. And So, and surprisingly, the physicians did. They gave a list of, and there's 15 plus specialties that have actually kind of coughed up this list of 5 things that are being done too much. An example would be, just so you know, antibiotics for acute sinusitis. It's done most of the time. Acute sinusitis is due to a virus. Antibiotics are not going to help in this situation, and yet frequently antibiotics are prescribed. So I'm mentioning this because it takes a concerted effort to move from where we are right now, where antibiotics are usually prescribed, to get to a point where antibiotics are prescribed for the appropriate indications. And the reason why I say this is, getting back to time, if you have 5 or 7 minutes, try convincing the patient, especially when you know that your bonus depends on patient satisfaction scores, try convincing that patient that they don't need antibiotics. In 5 or 7 minutes, the physician is just going to give they're going to give the antibiotics. And also, if the patient if they're not working in a situation where they become aware of the Choosing Wisely campaign, they're going to go into the physician absolutely certain that they need antibiotics, and if they didn't get antibiotics, they didn't get the right medication. So, and antibiotics is just the beginning. Another example is imaging for acute back pain. It happens all the time, but unless there's certain red flags, when somebody has acute back pain, imaging is not needed. And there's this phrase: the more you do, the more you do. So imaging is getting imaging in the setting in the first 6 weeks of acute back pain is that's sometimes one of the first things that can lead to a snowball of costs. Next thing you know, there's some abnormality on the imaging, and is it related or not? I don't know. Let's get some more imaging, or let's get a specialist involved, et cetera, et cetera. That is one thing that we are absolutely leveraging in our system, is the Choosing Wisely campaign. I just wanted to encourage you to take a look at it.
I think the other thing is that our providers are energized by being able to do the right thing. There are so many, the reason primary care is a shortage is because people don't really like their jobs. But they love these jobs. They love taking care of the whole person. When I started this, I thought, are people really going to be bored treating the same patient population day in and day out, versus in the community practice where they have a variety? In reality, what is happening is, in the community practice, they see the same disease with a different face on it. But in this practice, in the clinical, they see the whole person, and they're learning so much about the person. They're able to guide it. They're able to see an impact. They're able to make improvements. So the providers absolutely love it. And the patients and the members love it. The satisfaction is huge. And I would say it's the first time in my career that I've seen happy payers, happy providers, and happy patients. Who would have thought that would happen in all one organization? So we get 80% participation. We have high patient satisfaction. Everybody gets a form to fill out. We have 0 physician turnover. We've had 0 client turnover. We measure and improve the biometrics in health because we want to know that we're actually bending the curve. We're not just providing care, but we're actually improving care. And we want to make sure that we're providing a strong ROI so that you're actually being able to get your healthcare costs trend turned in the right direction. These are examples of our customers. Monroe County Government was our first one. And we usually take the ROI and we make sure that we remove the cost of the clinics, and then we get the results. So Monroe County is a government clinic. That's the first year. Elkhart Community Schools, we had a very active outreach program with Elkhart Community Schools. When you look at schools, they essentially are a near site clinic because they have so many buildings. You have to reach out to them. Our MAs did the screening, scheduled the physicals. We measured that. We managed their substitutes so people could get free for their comprehensive physicals. Indigo is the bus company for Indianapolis, inner city bus company. They're actually fully insured. So, but they couldn't go self-insured because their risk costs were so high. They were looking at a 45% increase. They are now, in 2014, they were paying less for their fully insured product than they were in 2009. And by the way, that population loves their providers. They were actually involved in helping select their providers. And I think when they ever have their breaks, they like to go down and hang out in the clinic. I'll tell you another interesting story we have for patient satisfaction. We have a beer distribution company And the number one benefit for that company has been free beer, which is really hard to beat. So the clinic now has been the number one benefit for the last 3 years. So we feel like we've made a dent there. Whenever we work with a company, we do a detailed analysis of 2 years of claims data. We do not want to go in and be an extra cost. We want to be a help, and we want to manage the total dollar. As I say about claims data, it's usually overstated because we know how to code really well, and it's underdiagnosed because we're not getting a lot of the population in that needs to be seen. But we will sit down and look at your specific data and create an ROI and really review the costs, the qualities, the opportunities. And that's a process that we feel is extremely important to go through. This is an example of our participation rate. The first year we had a lot of good participation. I will tell you what happens with a lot of patients are kind of test you out in the first year. You know, is it something I want to participate in? I hear good things about it. And then the second year, people start moving all their care over to the clinic. So a lot of people actually, this is their medical home. This is where they want to be treated. This is who they trust. Our providers actually go out and work in the location, so they orient to the companies. So our bus company, our provider ran out and rode the buses. Our beer distributor guy, he went out and rode the trucks while they distributed beer. They just really want to know what's happening in that culture and how can we best service the organization. You want to talk about that?
Yeah, we got the 5 minutes signed. So I would just say, you know, one of the most rewarding days that I've had since I've been here, I was in one of our clinics, and I was sitting with a health coach, and the patient graciously just allowed me to be there. You know, and this was a man that had hypertension, and through working with the health coach, had lost approximately 25 pounds, and he was still on some antihypertensives, but he had gone from 2 down to 1, and the question was on the table: should he, you know, go from 1 antihypertensive medication to 0? Was that clinically appropriate? But beyond that, I mean, this was a real guy with a real life who now was, I mean, he was feeling a lot better because he was in a better state of health, and this was having a tremendous impact on how much energy he had to interact with his family and also interact with his church, etc. And so, since we have only a couple minutes, that's what I would close with. That's what I think is the potential for medicine, and I'm glad that we're headed back in that direction.
Well, and I just want to say that working collaboratively as we do, trying to understand your culture, we want to make sure we're making a difference working jointly with you on what is your culture aware of, and do they know and understand the behaviors that could be causing them healthcare issues. We really want people to enjoy their retirement, not spend their dollars on retirement, trying to take care of their health. So we work hard to see improvements. So we measure that. We measure the culture. We also measure the difference we make. And so the other thing we want to make sure is, are we measuring cohort to cohort? Are we actually measuring and making an impact on that population? So we really believe that having the right primary care relationship along with the employers and everybody making it a priority of your human resources is a priority, and we really want to make sure that we're delivering a model that takes care of that.
I just had a quick question. We do a lot of cross-selling, a lot of property and casualty, along with our employee benefits practice. And how does this interface with workers' compensation claims and occupational health?
So again, it depends on the company, but what happens a lot of the time is we have one company where they wanted us to actually do the OSHA logs and the tracking and all of the reportables and non-reportables and measure that. And so we ended up hiring a family practice physician, and our nurse practitioner health coach was a workers' comp health person. So we can do that, but a majority of the time what happens is, because the population understands us and likes and trusts our provider team, we do a lot of the first worker injury. So they will come and we'll take care of that, because 95% of the time it's a primary care issue that we're taking care of. So we can do that. We will work with the carrier if there's a carrier that's monitoring and managing all the logs and the reportables, and we'll try to see if we can get our provider on that list to be a preferred provider depending on the state where the care is being given.
Any other questions?
Other question?
Oh, Tom, you have one? Oh, Amy's gotcha.
Impressive running with the shoes on that you have. Nice. Okay, so I'm sure you get this question every single time you give a presentation or talk about your program. Number one, what's it going to cost to build a clinic? But number two, how do you make the decision whether or not it's appropriate to do it at your plant or at your office versus close by in conjunction with other employers? And if you think it would be a good thing for you to do in conjunction with other employers, how do you get a bunch of people together to talk about this?
So we sell through TPAs and brokers because we believe they understand the total picture and the benefit plan design and the situation of the employers better than we do, and we try to partner with that. But I will say that if we want to open up, so the cost of the clinic and deciding if it's near site or on site really depends on the layout and access and the availability. You want a private entrance, you want to have your spouses and families and dependents coming in. So do you want a private entrance or not? I will also tell you this, that it is a patient-centered clinic, not a revenue-centered clinic. So you only need about 1,200 square feet or 1,500 square feet. So it really depends. It doesn't take that much space because it's centered around the patient. We typically do not do it as walk-in because we want to be respectful for the patient, that they don't wait. So we have them call so we understand. And as we know, patients will call and say they have a sore throat, but get in there and say, I have these three refills to do, and so on and so forth. So we do that very carefully, but it depends on the location. We have some companies that have security to get through. It's a challenge to get back to where they might want the clinic, so we would probably suggest a near site. And then we have found that when we have near site, we have a lot more family members participating because they don't have to go to the work site of their spouse or their partner. So it's really about access. We do a lot of mapping. Where do people get their health care now? What's the travel routes? All those things to determine what's a good location for people. The costs vary on mainly the build out and then the setup.
So when you set up these clinics and you have your own providers, medical providers, and you have these employees that have existing relationships with providers, how do you overcome that challenge of leaving one that's been trusted for many years and going to your facility?
A lot of times our employers will do incentives and encourage people to come and try the clinic, but I will tell you also, because we do that proactive physical, I will talk to employees who say, I've had a provider for 20 years. I always, having come from the healthcare side, I always tell people, I know that you've had that relationship for 20 years. We respect that and we appreciate that. We're not trying to get in the middle of that. But we'd also like to have you get a second opinion. Go get a comprehensive physical. At least use the coach. I will tell you that most of the time when people have experienced that, there's a lot of people who start moving their services. We're not trying to move that, though. If they're happy and we can help out and we find something, we'll say sign a release and we'll send that to your primary care. But we really want to be collaborative with the community. And I will tell you, we've been into communities where they didn't want us to come in, and 3 or 4 months later, everybody loves us because we have good relationships with the hospitals and the specialists after they see that we're really focusing on trying to get people healthy. We have a clinic in a community the size of 6,000 people. A lot of our clinics are in communities of 18 to 150, but we also have Indianapolis. We're looking at Milwaukee, should be opening soon, outside of Chicago. So it really depends. A lot has to do with commuter and where people travel and live.